treatments, overall hospital mortality in the AKI population was 60% more or less. The most common contributing factor was sepsis, but only 62% of the AKI population was treated. So are we sure we treat all the patients who require renal replacement therapy? And that's dependent on the clinical indication. And this slide was taken by Ravi Mehta, where he described the difference between renal replacement therapy and renal support therapy. So indication to start actually can be different, whether you have life-threatening situations or you may have conditions that may require the treatment to help the kidney. The other question is whether mortality or not has changed over the years. And the problem is that we have two different patients compared to the past. The mortality is more or less the same, but the patients are definitely different. And if you look at the database of our own institution, at the beginning, 74 to 79, 48 patients treated, only 15% in the ICU, while 95 to 2,525 patients treated, only 8% in the world, all the rest in the ICU. Mortality is the same, the case mix has changed tremendously. The question also is whether or not patients who do renal replacement therapy are exposed to a specific risk. Apparently, in this study by Mettins, there is a high risk when you have the need for renal replacement therapy. And patients doing renal replacement therapy, mortality is higher, length of stay is longer, hospital length of stay is longer. Nevertheless, over the year, mortality has progressively decreased, and in the last large trials done specifically on those, mortality rate has somehow decreased over time. Is this due to dose? Well, we don't know, but certainly, still in 2004 and then 2007, if you asked people how do you prescribe your dialysis, still you had a large quantity of people saying, I don't know how I am prescribing my therapy. So we are probably missing something in the equation. We're mixing different clinical settings, and we don't know whether RRT itself is a risk factor. So this makes adequacy of treatment in the iceberg when all the unknown aspects are under the water compared to what we base normally adequacy on. And therefore, the question when to start and when to stop have to take care of all these aspects that I just mentioned. The key questions today are therefore indication, timing, modality, and dose prescription. We have seen that it depends very much if you want to begin because you have a life-threatening situation or you require support. So there is a biological rationale to start early because actually there are some studies that seem to show that they may improve survival, renal recovery, and have a shorter duration if you start early. But the determinants of initiation depends on several issues, including how the conservative therapy was working, what are the goals for clinical management, and how different situations concerning other organs we are dealing with. How do we define timing? Based on symptoms, on biochemical markers, or relative to onset of AKI, ICU admission, rifle class. So there is no broad consensus to guide this. And before judging this, we must know that the current practice is enormously variable, and the surveys of practice have shown this, and there are limited quality of data. The fact that there is a current variability, and here I might disagree with my friend Robert Lemaire, I think is a very good sense that people still are watching at the patients rather than watching at the guidelines that in this case are not telling anything useful. But definitely, we have additional factors in renal replacement therapy initiation. If you are in a different country, type of institution, type of ICU, depending on whether or not you have resources. And there are people that say, well, I am in favor of an early start. I have theoretical advantages. I don't want to have a lot of derangements to develop. I want to treat the patient before it comes into a severe state. And this is a typical example that if you start early, you will never reach a level of uremic intoxication that you will achieve if you start late. But there are people that are somehow posing some skepticism. You may need a catheter, you potentially expose the patient to a catheter infection, to an extracorporeal circuit, to RRT itself. There are a few data, and they're based on biochemistry, and they seem to show a signal towards reduced mortality in patients who start with the lower level of serum urea. Basically, the studies seem to show that actually if you start early, you reach a steady state condition, but you may avoid the very early phase of acute serious derangement. Then, of course, there are other studies that have shown, like in this case, post-cardiac surgery, but as Roberta said, many of these studies are underpowered, they are very small, but they seem to show sort of stay in the ICU, some survival benefit. The Pickard study, and Ravi will comment even better, seems to have a signal for a better survival probability when you start early. And the best kidney study, that was a large retrospective analysis of prospective data collected in 54 centers, seems to show that based on, for example, relative to ICU admission and creatinine level, mortality seems to increase when you wait 5 or more days from the ICU admission to start renal replacement therapy. This is important because also in the meantime, the practice has changed. And in fact, in some centers, it has been shown that when they change the so-called door to dialysis time due to different practice, they might have seen improved survival and shorter duration of renal replacement. So based on some studies which have the quality that is questionable, however, both in randomized control trial and in cohort trial, you have a relative reduction of the risk for dying when you start early therapy. And there is also the point relevant to the fact that the fluid overload is considered a biomarker. And in most cases, when you analyze fluid overload, patients who survive tend to be less fluid overloaded compared to patients who do not survive. And especially if you express in terms of percent overhydration compared to baseline body weight. We have applied what today is called an IT sniffer. Basically, it is based on a database that prospectively collects data. You keep going, you have data on general details of the patient, so the system automatically looks at the different aspects. And the important thing is that we used both rifle criteria or King criteria to define AKI. And at a certain point, you have alerts. So it tells you, look, I don't know what you want to do, but just to let you know that you have achieved that level of AKI in the diagnosis and so on. So based on this, we have initiated the possibility to develop algorithms that somehow should be tested in clinical trials. What can we say about timing so far? There is little consensus on when to initiate. Early initiation probably improves outcome. I must say, because you don't want to listen from me just at pub event. You want to know what I think. What I think, I prefer to start quite early, but I want to see the patient before I say, let's go and let's start. Rifle and Akin stratification stages may represent an interesting surrogate of timing, so that we will not say early and late, but we can say we start at rifle high and so on. There is a rationale for early initiation, there are drawbacks for early initiation, objective argument has been proposed. We definitely need some additional studies. Let's see what the guidelines say. Well, more or less we can say that about this, the guideline agreed on the fact that the sky is blue. That's it. Because there was a very, very little exposure of, probably because there was not enough evidence to say that. So, when do we stop? Discontinue renal replacement therapy when it is no longer required. Thank you very much. We suggest not using diuretics to enhance kidney function recovery. That's interesting because, in fact, it has been analyzed that if you use a lot of diuretics in the patient, you may decrease your sensitivity and specificity in analyzing when you are capable of stopping the therapy, right? Now, what about timing? Initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid base exist. This is not great, but this is life. I mean, you know, I'm fed up about guidelines that say this is not great. What do you do? I mean, this is what you do. So we have to interpret guidelines with good sense. We have to teach our fellows to look at the patients and not just at numbers. Consider the broader clinical context. This is a good advice. This is very important because when you make a decision to start renal replacement therapy, every patient is a single entity. So, criteria for starting, again, life-threatening situation or no life-threatening but you may need support is one condition. Typical condition of life-threatening situations are those that you find in any type of book of intensive care nephrology. But any time you reach a potassium of 7, there must be a moment 3 hours before in which potassium was 6. So if you don't watch your patients, you may reach potassium of 9 and then you have emergency. That's where the nephrologist and the intensivist have to work together. You have to watch the patient, you have to follow. That's why I prefer to start when potassium is 5.5 rather than when potassium is 7. Anyway, so renal support, again, is a condition that may require the treatment to enable nutrition, diet delivery, volume control, regulation of electrolytes, salt modulation, and so on. There were no position about early or late in the guidelines. There is an interesting series of new studies. This is one which has been presented recently in Canada, showing what are the characteristics of the patient in Canada when they started renal replacement therapy. And they describe different conditions in terms of SOFA score, urine output, potassium, and so on. So you can somehow confront yourself with that situation. What was the trigger? Well, hyperkalemia most of the time, no uniformity about rational, no clinical factor playing an important role. I must say that in our reality, probably volume is definitely one of the most frequent triggers for starting renal replacement. The reality around renal replacement therapy initiation is that there is no true standard of care, which may be a good thing, again, because you may want to judge a patient by patient. The problem is that if you see a patient that requires renal replacement therapy, from that moment, treatment should be instituted and be there in 1 hour. There's no reason to wait for 7 hours, 12 hours, and so on. And, you know, to tell you the truth, there are some discrepancies, for example, comparing the renal trial and the ATN trial, when you see that the door to dialysis from ICU admission were so different, you really don't know exactly what were the factors affecting the start and the decision to decide. There are plausible reasons to support earlier initiation, again, if you want to improve volume control or reach early correction or avoid morbidity associated with complication guided. And again, we have presented the results of the Picard cohort who commenced the RRT after adjustment for the propensity to receive late renal replacement therapy, where it was associated with a twofold risk of death. Again, in this study of Carvelas, there seems to be a reduction in the relative risk when you start early. And I was mentioning the ATN and renal trial. You see the door to dialysis from ICU admission, 171 hours compared to 51 hours. So there is something that also is important because there were differences in mortality, 52% at 60 days, 45% at 90 days, and dependence on renal replacement therapy at 60 days and 90 days. But we have reasons to be cautious. Definitely, most definitions are problematic. because BUN, creatinine threshold, duration of ICU stay, vital, they not really address the actual duration of kidney injury. Only 10% of people normally receive renal replacement therapy, and we don't really know if we are treating all the right patients. Our ability to predict progression is rudimentary, and exposure patients to risk vascular access may not be justified sometimes. There are measured confounding observation. It can't be certain that individuals with high BUNs were not inherently different from those with low BUNs in the studies that were performed. The largest trial done, which is the BAUM trial, basically compared early hemofiltration with late hemofiltration, 7 hours versus 42 hours, different urea levels. The trial results showed that the late patients seemed to have less mortality, also recovery and function, which was quite curious. The study was definitely underpowered. Its generalizability was questionable. At the end, it was quite inconclusive. So, another message: do not quote the studies, but do not misquote the studies. Quote the study, but do not quote the abstract. Read the paper, not just the abstract, because sometimes reading the paper you find a lot of interesting things. Why is a definitive trial needed? Because we like to know. Since this is the most frequently asked question, when to start? An early RRT approach may harm patient or may be of beneficial. Is adoption of this approach occurring anyways in spite of lack of evidence? They have in Canada started this called START AKI trial. It's a randomized open-label pilot trial of accelerated versus standard initiation of renal replacement therapy in 12 academic centers. They are classic inclusion criteria with evidence of severe AKI based on 2 of the following criteria. For the first time, we are introducing the concept of the biomarker, which still problematic. Criteria for renal recovery permitting withdrawal RRT. The primary outcome is to have 90% in each arm of the people adhering to the protocol, and the fact that more than 50% are eligible. The follow-up is at 90 days, and they want to look for safety related to RRT and vascular access specifically. They have been actively recruiting. 81 patients enrolled last week. Plans for definitive principal trial underway, and so far there were no significant safety concerns. So, current practice is valuable. Initiation before life-threatening indications are evident in some studies, and they become to be increasingly accepted. This approach has plausible benefits, but also significant potential harms. A definite trial is needed or not. I don't know, because again, unless we are going to be able to design the very, very good trial, we have to stop spending money in useless trials that are only applicable to the population to which the trial has been addressed. So this is complicated. This is a complicated issue. My recommendation, especially to the young fellow here, is look at the patient, watch it carefully. Norbert is right. You may not need any type of biomarker if you do creatinine every 6 hours, if you look at the patient very carefully. But Norbert is wrong also. You may need and want to add other parameters and look even more in a sophisticated way to this patient. There is a need for careful monitoring of this patient. There is a need today for critical care nephrology. Let me do some commercial and invite everybody to come to Vicenza for the critical care nephrology meeting in 20 days from now. Thank you very much.